Hello, this is Chloroquine and Hydroxychloroquine, a review of pertinent drug information for SARS-CoV-2. My name is Zahra Kassamali Escobar. I'm a clinical pharmacist in infectious diseases at UW-Medicine Valley Medical Center in Renton, Washington, and a clinical assistant professor at the University of Washington School of Pharmacy. The data in this presentation are updated as of August 7th, 2020. Updates in this presentation include efficacy data. So we have two randomized controlled trials. One is a multi-center trial looking at hydroxychloroquine plus or minus azithromycin in mild to moderately ill hospitalized patients. And another is looking at the recovery trial specifics. And also we'll be examining some safety data from these multi-center randomized controlled trials. First things first, chloroquine versus hydroxychloroquine. On the left-hand side of this slide, you can see the chemical structure for chloroquine, and on the right-hand side, you can see the chemical structure for hydroxychloroquine. Hydroxychloroquine is quite literally a hydroxyl transformed version of chloroquine. Both of these molecules is independently active against COVID-19, and they are also metabolized by P450 enzymes to active metabolites, which include some of the same ones like desethylchloroquine. The proportion of metabolite conversion can vary, and the relative activity of parent compound versus metabolite is unknown. According to the package insert, hydroxychloroquine is available as a 200 milligram tablet. This is the salt form, which contains 155 milligrams of base or active drug. There are 3 FDA-approved indications for hydroxychloroquine, which include malaria treatment, rheumatoid arthritis, and lupus. The dosing for each of those is listed here on the table on the left-hand side. You can see that for malaria treatment, the dosing recommendations are highest compared to the other 2 diagnoses, with loading dose of 800 milligrams, followed by 400 milligrams daily. For chloroquine, this medication is available as a 500 milligram tablet. This is the salt form, and the active drug is 300 milligrams of base. I specify that because in some publications and references, chloroquine dosing is referred to in terms of the base rather than the salt form. As little as 1 gram may be fatal in children, and this is particularly relevant for chloroquine because the therapeutic dose, at least for adults loading in malaria treatment, is also 1,000 milligrams. That's followed by 500 milligrams for 3 doses. In terms of hydroxychloroquine in COVID-19, this table includes a list that's not comprehensive of different dosing regimens that have been utilized for hydroxychloroquine. Some include loading doses, others do not. I want to point out that the emergency use authorization from the FDA was retracted on June 15th, and they cited a few different reasons, including that the suggested dosing regimens for both chloroquine and hydroxychloroquine are unlikely to produce an antiviral effect, and they said that earlier observations of decreased viral shedding with hydroxychloroquine or chloroquine treatment have not consistently been replicated, and then recent data from randomized controlled trials showing lack of efficacy in COVID-19 has also informed this decision. The same is true for chloroquine dosing in COVID-19. You can see that there was an FDA emergency use authorization that came out in April, but again, that is part of the same retraction as hydroxychloroquine. I want to point out that there was variety in the regimens that were used for chloroquine dosing in COVID-19, and specifically if you look down to the 5th line of this table, the study that was done in Brazil, they had to stop their 600 milligram BID times 10 days arm early because of an increased rate of adverse events, specifically cardiac toxicities that were seen in that high dose arm. The mechanism of action is twofold. It's proposed. First, direct antiviral activity This is mediated by intracellular alkalinization, which inhibits pH-dependent steps of viral replication and impairs viral receptor glycosylation. Secondly, these drugs cause immune modification, meaning they can reduce cytokine production, specifically IL-1 and IL-6, and inhibit toll-like receptor signaling. For antiviral activity, the PD, or pharmacodynamic target, we can use to estimate how to target our dosing is EC50, which is the drug concentration required to achieve 50% of maximum observed SARS-CoV-2 elimination, or just 50% of viral replication. For immune modification, we really don't know what the pharmacodynamic target is, but there have been some proposals. With respect to hydroxychloroquine dosing and pharmacokinetics, what we know, or what we've seen, is the volume of distribution is massive. 2,000 to 5,000 liters has been seen in one healthy volunteer study in South Korea. The half-life ranges from 5 to 40 days, and serum concentrations that were seen in one study of critically ill patients with COVID-19 infection ranged from 0 to 2 milligrams per liter. Of course, if we're thinking about treatment of infection, probably what is more relevant than serum trough concentration may be the concentration of drugs in the pulmonary site, which is where the virus is replicating. In terms of QTc prolongation and cardiac toxicity, evidence suggests that patients with underlying cardiac comorbidities are disproportionately affected by COVID-19, and the virus itself provokes myocardial injury. However, we are concerned about the independent prolongation of QTc by hydroxychloroquine, which is a known side effect of this agent. Mercuro and colleagues conducted a single-center retrospective investigation looking at about a month's worth of data in Boston, Massachusetts. They identified 90 inpatients with positive SARS-CoV-2 PCR and who received at least 1 day of hydroxychloroquine. Of those 90 patients, 37 received hydroxychloroquine monotherapy, the dosing is listed on the slide for your information, and 53 of the patients received a combination of hydroxychloroquine and azithromycin. The initial QTc interval in the patients who received hydroxychloroquine monotherapy was 474 milliseconds and increased to a post-treatment peak of 480 milliseconds. The initial QTc interval for patients who received hydroxychloroquine and azithromycin as a combination was 442 milliseconds and increased by 23 milliseconds to a post-treatment peak of 458 milliseconds. The patients in each of these groups were relatively similar, although more patients in the combination arm numerically were admitted to the ICU and required supplemental oxygen compared to the number of patients in the hydroxychloroquine monotherapy group. The authors looked at prolonged QTc intervals defined as greater than 500 milliseconds and found that the number of patients who met that criteria was similar between both groups, 19% in the hydroxychloroquine monotherapy and 21% in the combination therapy arms. However, delta QTc greater than 60 milliseconds, the rate of that occurring happened more often in patients who received a combination of hydroxychloroquine and azithromycin, which is certainly concerning because we know that both of these agents can prolong the QTc interval. And one patient among this group of 90 actually had torsade de pointe, which led to discontinuation of this therapy. For incidence of cardiac toxicity, these data come from randomized studies. Again, we know that patients infected with COVID-19 who are hospitalized have increased cardiac events. And so the randomized studies allow us to see the contribution of patients who received hydroxychloroquine versus a control to understand the contribution of hydroxychloroquine to that cardiac toxicity. So starting from the top of this table, the first study I want to point out is the recovery trial, which I'll be talking in more detail towards the end of this presentation. And this was 1,561 patients on hydroxychloroquine compared to about 3,000 patients who received standard of care. Now there's some relevant exclusions. In this case, it was patients with known prolonged QT intervals. QTc prolongation was not reported in the paper that they published. However, they did report on cardiac toxicity. And what you can see on the top right-hand corner of this table is that supraventricular tachycardia occurred in about 7% of patients in the hydroxychloroquine arm versus 6% in the standard of care arm. You see VTAC or fibrillation occurring in 0.9% of patients who received hydroxychloroquine versus 0.7% in the standard of care. Atrioventricular block requiring treatment occurred in 0.1% of both arms, and then there was one case of torsades that occurred in the hydroxychloroquine treatment group. Overall, the toxicity looked similar between hydroxychloroquine and control arms. Now, the recovery trial included patients who had high oxygen requirements and including invasive mechanical ventilation. But Cavalcanti et al. Conducted a study looking at hydroxychloroquine plus or minus azithromycin in patients who were mild to moderately infected. So that was defined as an oxygen supplementation requirement of less than 4 liters per minute. So we're talking more about mild to moderately ill patients, but still hospitalized. The relevant exclusions here were that patients with severe V tachycardia or a history of QT intervals greater than 480 milliseconds. And so they looked at QT prolongation across their 3 groups. So again, we have the combination of hydroxychloroquine and azithromycin, hydroxychloroquine and control. And for prolonged QT interval, you can see that both of the hydroxychloroquine treatment arms had a rate of prolonged QT more than 480 milliseconds of 15% versus only 2% in the control. Now, I also want to point out that the number of people who were actually tested who had electrocardiographic or EKGs done was much lower in the control arm compared to each of the hydroxychloroquine arm. So there might be a reporting bias there too. As far as cardiac toxicity, arrhythmias occurred in 1.3 and 1.5% of each of the 2 hydroxychloroquine arms versus 0.6% of the control arms. You can see the rates for supraventricular tachycardia. There were no events for VTAC, and there was 1 MI that occurred in the combination therapy group versus none in the other 2. Finally, the last line of this table at the bottom, Lofgren et al. Looked at safety data across 3 randomized controlled trials of hydroxychloroquine versus placebo for pre-exposure prophylaxis, post-exposure prophylaxis, and preemptive early therapy. Now, this was a study, these 3 studies were all done on outpatients and generally conducted as surveys or phone calls between study personnel and participants in the study. So EKGs were not done as part of the study, although patients who were hospitalized with an arrhythmia were recorded. There were again, relevant exclusions, including known history of structural or ischemic heart disease, being on meds for arrhythmia, or known prolonged QT. And then what they reported, so the data that they reported with these arrhythmia events only came from the pre-exposure prophylaxis study, which went on for 12 weeks. And 1 person in the hydroxychloroquine arm who receiving hydroxychloroquine twice weekly had an arrhythmia for which they were hospitalized. 1 person in the placebo arm had an arrhythmia for which they were hospitalized. Overall, across each of these 3 randomized studies, of patients of varying severity of presentation with COVID-19 illness, cardiac toxicity was a low-frequency event and no different between the hydroxychloroquine and control arms. This is a timeline of the available data we've had for hydroxychloroquine to treat COVID-19 from the beginning, March, until recently, as recent as July 23rd. And I just want to put this here to put it in perspective of how much information we've gotten over these last few months, as well as the size of the trials. We went from studies with 30 patients in March to the thousands in June and July. As I mentioned, this is the most recent randomized controlled trial. This was published on April 14th. This is a multi-center parallel open-label randomized trial across 16 centers in China. This was done in February 2020. Their intervention, this is interesting because this is the highest dose I've seen so far of hydroxychloroquine, but they used 1,200 milligrams daily for 3 days, then 800 milligrams daily for 2 to 3 weeks versus plus standard of care versus standard of care alone. Now, what I don't know for sure is whether standard of care included other pharmacotherapy. It's not clear yet on this paper. Anyways, that primary outcome they wanted to look at was viral suppression. And patients from onset of disease to randomization, the average time was 16 days, so over 2 weeks. So if we look at the graph on the bottom left-hand side, we're looking at positive SARS-CoV PCR, SARS-CoV-2 PCR on the y-axis. And the blue line is the hydroxychloroquine plus standard of care. The red line is standard of care alone. And you can see there's really no difference within those 28 days that they looked at it. Among their secondary outcomes was clinical improvement. So this was resolution of fever, improved oxygen saturation, improved respiratory symptoms. And again, we're looking at cumulative improvement on the y-axis by percentage and days from randomization on the x-axis. And you can see there's really no difference, and there was no statistically significant difference between standard of care and hydroxychloroquine versus standard of care alone. On May 11th, Rosenberg and colleagues published a retrospective multi-center cohort of COVID-19 inpatients. They looked at 25 hospitals in the New York metropolitan region in the month of March, and in that time they identified almost 8,000 patients. They randomly selected 30%, or roughly 30% of the patients per hospital, so that was 2,362 patients. And then the patients who were published in this publication included 1,475 patients who were abstracted. There are 4 different treatment arms: a combination arm of hydroxychloroquine and azithromycin, that was about half of the patients, a monotherapy arm with hydroxychloroquine, 19% of the patients, azithromycin monotherapy, 15% of the patients, and then neither drug, which was another 15% of the patients. As with any observational study where the treatment is decided by the provider, there were baseline differences among patients who received hydroxychloroquine either as monotherapy or in combination therapy, and those who received azithromycin either alone or neither drug. So these included that the patients who had hydroxychloroquine in their regimens were more likely to have diabetes or be obese. The patients in the hydroxychloroquine arm, there were more of them with chronic lung conditions and more of them who had congestive heart failure. And then the severity of their COVID-19 presentations in patients, again, who received either hydroxychloroquine by itself or in combination with azithromycin was greater. They had more tachypnea, lower oxygen saturation initially, and more increased rates of abnormal chest X-ray findings versus those patients who received azithromycin alone or neither drug. As a group, we do not know how long patients were ill prior to their admission. So the primary outcome of the study was in-hospital mortality. And if you look on the lower left-hand side, you can see in-hospital death on the y-axis and days after admission on the x-axis. The group of patients who received combination with hydroxychloroquine and azithromycin numerically had the highest rate of in-hospital death This was followed by patients who received hydroxychloroquine as monotherapy, as well as patients who received neither therapy. Those two lines look basically superimposed on this chart. And then finally, the patients who received azithromycin alone had the lowest rate of in-hospital death. Now, when these results were adjusted for age, sex, past medical history, oxygen saturation, lab abnormalities, and chest imaging, this was found to not be a statistically significant difference. The secondary outcomes of the study were cardiac arrest, arrhythmia, and prolonged QTc interval. And so on this table, on the right-hand side, you can see the different therapies listed across the top and the comparator below. So each of them were compared, each of the treatments was compared to no treatment, and then hydroxychloroquine was compared to azithromycin. In terms of cardiac arrest, there was an increased rate of cardiac arrest in patients who received regimens that included hydroxychloroquine, and this was statistically significant in the patients who received combination of hydroxychloroquine and azithromycin versus patients who received neither drug. With regard to abnormal EKGs, you can see again that the patients who got regimens which included hydroxychloroquine had an increased rate of abnormal EKG findings, which included arrhythmia or prolonged QTc. None of the results compared to in any of these comparisons was statistically significantly different. The Detroit study is a really interesting study to look at because it has a very similar study design as the study from New York, but opposite results. So this was a retrospective multi-center cohort of COVID-19 inpatients across 6 hospitals in Southeast Michigan, of which Henry Ford is the largest. This was included 2,541 patients in 4 treatment arms: hydroxychloroquine plus azithromycin, hydroxychloroquine alone, azithromycin alone, or neither drug. So the primary outcome was in-hospital mortality, and on this graph you can see survival probability on the left-hand side, or the y-axis, and days after admission on the x-axis. And the black and green lines represent the two study arms of patients who received hydroxychloroquine. And the rate of in-hospital mortality was lower in these groups compared to the patients who received either azithromycin alone or neither treatment. So that was a statistically significant reduction in mortality. However, when we think about baseline differences in the patients in each of those study groups, because they were not randomized, right? They were selected by the treating prescriber. And there was certainly differences, but the one that really stood out was the use of dexamethasone. And what you can see in this table is the top 2 lines represent each of the study groups with hydroxychloroquine. And use of dexamethasone was 75 to almost 80% in those 2 arms versus 36 and 39% in the other 2 treatment groups. So the authors, to their credit, ran a propensity-matched analysis matching on age and comorbidities, as well as use of these additional or concomitant therapies. I think oxygen utilization and admission to the ICU. So matching them this way, they compared patients who received hydroxychloroquine versus no hydroxychloroquine, 190 of them in each group. And again, we're looking at survival probability on the y-axis and days after admission on the x-axis. And the difference in mortality persisted with hydroxychloroquine resulting in less mortality versus patients who did not receive hydroxychloroquine. The recovery trial is a randomized evaluation of COVID-19 therapy. It's a trial that was initiated and being carried out in the United Kingdom. Patients were randomized to either receive no treatment, lopinavir, ritonavir, corticosteroids, hydroxychloroquine, or azithromycin, and simultaneously they were randomized to receive either no additional treatment or convalescent plasma. Finally, for patients who had persistent progressive disease, there was a second randomization where they could receive no additional treatment or tocilizumab. As far as the hydroxychloroquine arm of the study, patients received a 10-day course of hydroxychloroquine, which started with a load of 800 milligrams, then another 800 milligrams 6 hours later, followed by 400 milligrams every 12 hours. Again, this was for a total of 10 days. Patients were followed up until death, discharge, or 28 days after randomization, and the primary outcome was the effect of the study treatments on all-cause mortality at 28 days after first randomization. Results from the recovery trial were released initially as a press release on June 5th and then as a preprint on July 15th. Altogether, 1,542 patients received hydroxychloroquine and were compared to 3,130 patients who received no treatment. The table in the middle shows their baseline characteristics, and you can see that overall the two treatment groups are very well matched in terms of age, sex, and comorbidities. Oxygen supplementation was required by 60% of patients in both groups. Invasive oxygen supplementation or ventilation was required by 17% of patients in both groups, and about a quarter of them did not require any oxygen supplementation. The bottom line of the table shows some concomitant treatments, and I want to point out that dexamethasone was used in 8 and 9% of patients in both groups. 28-day mortality was 23.5% in the patients who received no treatment versus 25.7% in the patients who received hydroxychloroquine. The hazard ratio was 1.11. You can see that this was not a statistically significant difference. The investigators looked at certain subgroups to see if there were populations for whom hydroxychloroquine may have shown benefit. These included age, days since symptom onset, respiratory support at randomization, and baseline risk, or how sick the patients were, comorbid conditions, for example, at baseline. And you can see from this forest plot that none of those factors had a bearing on making hydroxychloroquine work better versus usual care in terms of mortality. On July 23rd, Cavalcanti et al. Published their study, Hydroxychloroquine plus or minus azithromycin in patients with mild to moderate COVID-19. This was a multi-center, randomized, open-label trial conducted in Brazil. They included patients who were at least 18 years old and within 14 days from the onset of their symptoms. They were focused on looking at patients with mild to moderate disease, so they only included patients who had no oxygen supplementation requirement or an oxygen supplementation requirement that did not exceed 4 liters per minute. Notable exclusions are listed below. The treatment groups were hydroxychloroquine and azithromycin, hydroxychloroquine, or control. And those control treatments were standard of care, and so patients who received hydroxychloroquine could have received them as well. Now, I want to make a comment that the antivirals received in the control arm did not include remdesivir, which was not available in Brazil at the time of this study. The primary outcome was clinical status on day 15, and they used a 7-level ordinal scale. So the lower numbers represent the least sick patients. 1 is not hospitalized with no limitations, and 7 represents death. So what you can see on this graph is the first box on the left-hand side includes patients at levels 1 and 2. So both of those patients groups were not hospitalized, but they were not able to reliably adjudicate patients with limitations and patients without limitations after the patients had been discharged. Group 3 were patients who were hospitalized without an oxygen requirement. Group 4 were patients hospitalized with an oxygen requirement, and as you go through 5, 6, and 7, they get increasingly more oxygen and more invasive methods of oxygen delivery until death. And what you can see here visually is that there was no significant differences between the 3 treatment arms, and there was no statistically significant differences either. With regard to hydroxychloroquine in non-hospitalized adults with early COVID-19, this is a study that was really innovatively designed by Skipper and colleagues using internet enrollment and online surveys. They didn't find any difference between hydroxychloroquine versus no hydroxychloroquine or placebo, but there's a couple really significant limitations. Number one, it was underpowered and the enrollment was really not a very diverse enrollment of patients who were generally young and healthier than the patients we see in the hospital. And then secondly, and most importantly, is that this limitation that they pointed out themselves, which is only 58% of participants received SARS-CoV testing because of severe US testing shortages. Because of the record of safety using hydroxychloroquine for chronic conditions like rheumatologic arthritis or rheumatoid arthritis, as well as a delayed onset kinetically, this drug was evaluated as a potential agent for post-exposure prophylaxis. And this is a randomized controlled trial by Boulware and colleagues that was published on June 3rd. This was a multi-center, double-blind, placebo-controlled trial, and enrolled in US and in sites in Canada. The primary outcome was to look at new COVID infections between patients who received hydroxychloroquine or placebo. And as you can see here, the bottom line is that while there was slightly fewer infections in the hydroxychloroquine arm, the difference was not statistically significant. So what they did is they randomized patients who had a known exposure to a COVID-positive patient, and they defined that as an exposure that was within 6 feet for more than 10 minutes. High-risk exposures were patients were people who were exposed to known COVID-positive patients without a face mask or eye protection. Moderate risk exposure were patients who were exposed with a face mask but no eye protection. The majority of patients included in this study, about 2/3, were healthcare workers. The patients were randomized within 4 days of exposure to either hydroxychloroquine, the regimen is listed there, or placebo. And then new COVID-19 infection was defined as either confirmed, probable, or possible. And as you can see, confirmed was a positive SARS-CoV-2 PCR, but most of the patients did not have a PCR confirmed infection. Most of the patients were identified as having an infection according to their clinical symptoms. So 74 had probable infection, which was defined as cough, shortness of breath, difficulty breathing, or at least 2 of the following symptoms: fever, chills, rigors, myalgia, headache, sore throat, olfactory or taste disorder. 13 patients had possible COVID-19 infection, which is defined as at least one of the symptoms compatible with COVID-19 infection. So this study showed us that post-exposure prophylaxis was not effective in preventing infection or symptomatic infection among patients who are exposed to known COVID-19 positive patients. This is a Spanish study, a cluster randomized controlled trial of hydroxychloroquine to prevent COVID-19 transmission and disease. And it was really thoughtfully done. This was patients who were exposed to known index cases, so clusters of patients who were then randomized in their cluster to either hydroxychloroquine or control, so no hydroxychloroquine. This was open label. So altogether, the investigators identified 754 index cases, and they assessed them. And each of them had a cluster or ring of health contacts that were linked to them. And those index cases were confirmed PCR positive. So the median size of their cluster was 2 people, but it ranged from 1 to 3 in the interquartile range. The majority of these clusters were actually nursing home related. About half were nursing home workers, and then 13% in the control and 12% in the hydroxychloroquine arm were nursing home residents. The remainder, 12% 28% and 27% in the control and hydroxychloroquine arms respectively were household contacts and clusters, and then 11% and 12% were healthcare workers. So there were 334 control clusters and 338 hydroxychloroquine clusters. And the investigators initially evaluated them in their home and did a SARS-CoV-2 PCR test, and then followed up by phone. And then at 14 days, they were looking for PCR positivity in symptomatic disease within 14 days. So that was a primary outcome. So you can see that on the first graph in the middle of the slide, we're looking at percentage on the y-axis. The percent of patients with PCR positive and symptomatic disease within 14 days was 6.2% in the control arm versus 5.7% in the hydroxychloroquine arm. This was not clinically nor statistically significantly different. The following graph is of these people. They looked at those who were initially PCR negative at baseline. So these are the contacts who had their initial PCR screen. The majority of those people, 2,000 of them, were negative at baseline. And you can see that there was really, again, no significant difference between the patients in the control and hydroxychloroquine treatment arms. And then among the patients who were PCR positive at baseline, again, these are the contacts, not the index cases. They were positive at baseline, but they were given therapy early, so we can kind of consider this preemptive or early therapy with hydroxychloroquine. You can see that 19% of those in the control arm progressed to symptomatic disease within 14 days versus 22% in the hydroxychloroquine arm. And I'll mention too, the study not only was really nicely designed and well organized, but they reported that their adherence to the therapy was over 95%. So in summary, we continue to see that the randomized controlled trial data are showing no evidence of clinical benefit of hydroxychloroquine in a range of patients, very sick patients that we saw in the recovery study, all the way to mild to moderate patients, as well as post-exposure prophylaxis or even early preemptive therapy. Now, we had original concerns about harm, including overdose and QTc prolongation, but as we dialed down into these data and looking specifically at randomized controlled trials, the rates of cardiac toxicity were not different between hydroxychloroquine and control arms. Now, that being said, those patients who are maybe at highest risk of those cardiac toxicities, some of those were excluded from receiving hydroxychloroquine, so we do need to bear that in mind. And then there's still this issue that retrospective studies have shown possible benefit, and that gives a hint that maybe there's specific populations, potentially those who have some underlying inflammatory diseases, whom this drug may help, and or that placebo is really an effective therapeutic. This drug has had a lot of opinions circulating around it, and that effect really cannot be ignored.